Okay, good morning, everyone. I would like to welcome you all to this session, which is on the recent advances in cardiovascular protection and regeneration. And there are going to be 4 talks in this session. And our first speaker is Dr. Lei Xiao, and he's going to talk about recent advances in cardiopulmonary disease research. So please join me in welcoming Dr. Lei. We look forward to your talk, Dr. Lei.
Thank you, Dr. Singh. Let me just share my presentation. Where was it? I will see that earlier. Just give me one more second to share it. I'm going to try to speak because I'm using that online version, so sometimes it's difficult to find it. Why I don't see that? We just shared it earlier, and we can see that at that time, but somehow I don't see that.
You can just try to share your screen.
Yeah, that's what I was doing right now. I shared it earlier, but now I try to share it and open the window, and I don't see the slide show up. So that's the problem right now. What's going on here?
Excuse me, maybe you can just open your slides first and then try to share your screen.
Let me see the. Yeah, okay, let's do that again. Yeah, that's probably the reason why. Yes, you are right, absolutely right. Yeah, so now I'm sharing. Yeah, I have to open that. Okay, so I guess you guys can see my title, right?
Yes, our slides now. Right. Thank you.
Okay, all right. Thank you. So first of all, I want to thank the meeting organizer for inviting me to give this talk. This is my title, The Recent Advances in Cardiopulmonary Disease Research. My name is Lei Xiao. I'm the program director and the medical officer for the lung vascular biology program at the NHLBI in the United States. Basically, my job and my role is to manage all the clinical and basic researchers in pulmonary vascular disease in the United States, funded by NIH. So this is my disclaimer. So what I'm going to present today is only my personal opinions about this field, and doesn't necessarily reflect any views of the following parties, including NHLBI, NIH, HHS, or US government. So when we talk about a cardiopulmonary disease, normally we talk about a pulmonary vascular disease, which is called the PVD. And for PVD, we are talking about the 3 major diseases. One is the pulmonary hypertension. The second one is pulmonary embolism. And the third one is the last stage of the pulmonary hypertension, which is the right heart failure, which causes the patient death. The definition of pulmonary hypertension is the main pulmonary artery pressure over 20 millimeter mercury. So this is one of the deadly disease in cardiovascular field, currently without a cure. And without the treatment, the patient normally could not survive more than 3 years after diagnosis. And even with the current treatment, the patients will after 5 years, only 54% of patients will survive after 5 years. So this is really a deadly disease. It's the cancer in cardiovascular disease, all right? And it's understudied area. So this is the current classification for pulmonary hypertension. According to the 6th World Symposium on PH, which is pulmonary hypertension in 2018, currently we classify the disease into 5 different groups. Group 1 is the classical pulmonary arterial hypertension, called the PAH. That's group 2 is the PH due to the left heart disease. For example, right heart failure can cause the pulmonary hypertension. And the group 3 is the PH due to the lung disease or hypoxia, like COPD, asthma, and other hypoxia problem cause the PH. So that's group 3. The group 2 and group 3 are the largest populous groups in this disease. And group 1, PAH, is a rare disease. But it's the most studied disease in this pulmonary hypertension group patient. And then group 4 is sometimes called the CTEPH. It's the PH due to the pulmonary artery obstruction, mainly because of a pulmonary embolism that caused this disease. And then group 5 is the small group that with the unclear mechanism or multifactorial mechanisms. So currently, by the year of 2024, before 2024, we only have 14 drugs approved by FDA to treat group 1, which is PAH patients. And these are the mechanisms. All the 14 drugs can be classified into 3 categories, or we should say 3 pathways. One is the endothelin pathway. The second one is nitric oxide pathway. And the third one is the prostacyclin pathways. Those are the drugs: bosentan, ambrisentan, macitentan, and sildenafil, tadalafil, and all the Relsiguan, and all these drugs. So you can see they acting on different mechanisms, but they only have one common mechanism, which is a vasodilation. Okay, so they have different excuse me, molecular mechanism, but their effect is to dilate the blood vessel, which can allow the more blood flow to go through the lung and to have balance the ventilation and the blood flow. However, as we know that pulmonary hypertension is different from the systemic hypertension. That's what we normally talk about hypertension. Patient have hypertension. The systemic hypertension normally caused because of the vasoconstriction. Therefore, any vasodilation drug can cure or not cure or can manage the disease. So just relax the blood vessel and the blood pressure will go lower. However, in the case of pulmonary hypertension, which is totally different, the problem is not mainly caused by the vasoconstriction. It's mainly caused by the proliferation of the endothelium cells, smooth muscle cells, or the embolism that block the pulmonary artery. So even you try to dilate the blood vessel, it doesn't help much. It could dilate to a certain extent, and then you cannot further dilate it because the blood vessel is blocked. It's because the blood vessel is very narrow. The risk isn't very high. So that's why the disease is still deadly after so many years. Okay. However, the whole thing changed after 2024. So that's why I consider this is the most significant recent advance in the cardiopulmonary research, which is my main topic today. Because in 2024, on March 26, FDA approved a new drug called Regeneration. This is the brand name. This is a drug from Merck and company. It's a generic name called sotatercept. And this is the totally biologic drug. It's a fusion protein with IgG, Fc fragment, and the receptor binding domain together as a ligand trap. So this drug, the unique part is, first of all, it's as I mentioned earlier, it's a fusion protein. It can be injected into patient every 3 weeks. And it's on top of the background therapy. Still the patient can gain benefits after the background therapy. By saying background therapy, it means the patient already accept these 14 FDA-approved vasodilation treatment in the past years. But on top of that, if you give them the sotatercept, they can still make a difference. And the sotatercept is really a hot topic in this field, and it has published in the past 4 years. It landed into 4 papers published in the prestigious New England Journal of Medicine. I'm going to go through them briefly next. But before we go there, we want to just briefly introduce the mechanism for this drug. It's called sotatercept. So as some of you may know that one of the genes that linked to the PAH, which pulmonary arterial hypertension, is the BMPR2 gene. They found that a lot of patients with this gene mutation will develop pulmonary hypertension. However, not all the patients have this gene mutation, and not all the patients who have a mutation of this gene will develop pulmonary hypertension. But these two are closely linked. And because this pathway we know is anti-proliferative. So, but with the mutation of this gene, this protective effect will be decreased. So that causes the proliferation of the pulmonary artery endothelium cells and the smooth muscle cells. Okay, but on the other side of the same this way it's called the balance. On the other side, there's also a group of receptor called the activin receptor 2A or 2B, the 2 different receptors. And their ligands is called activins, and the CDFs GDF, growth differentiation factors. So those are in the superfamily of the TGF beta. It's the proliferation and also inflammation. So the drug, when they bind to the receptor, activating receptor 2A, it activates SMART 2 and 3 pathway and then cause the proliferation, which is a counter effect for the anti-proliferative pathway of BMPR2. So basically, this is balance. This is a stimulate proliferation. This is anti-proliferation. So in the patients with pulmonary hypertension, this pathway is active, and so they keep causing the proliferation of the smooth muscle cells. And for the sotatercept, it has a fusion protein. This part is the IgG-Fc fragment, and this is the receptor binding domain, just like here. So this is the fusion protein will trap or bind to the activin in the bloodstream and remove it from bloodstream. So basically, it is weakening the signal stimulation. This is a proliferative pathway. So that's a really smart design. It's a biologic, it's fusion protein. There's not much side effect, we know, for just the protein alone. But it can effectively remove activin, remove the proliferative signaling. So this is how the drug works. And as I mentioned earlier, there are 4 papers published in the same journal, New England Journal of Medicine, in the past 4 years. And the first paper was published in 2021 on April 1st, which is the result of the Pulsar trial, which is a phase 2 trial of this drug. This is the sotatercept. And then the next trial is called the Stellar trial, and published like 2 years later. It's a phase 3 trial. So let's start with the Pulsar trial. Pulsar trial, I won't go into the detail. I just show you the most significant result that lead to success of this trial, which is they are measuring the pulmonary vascular resistance changes after the patient received the sotatercept for 24 weeks, and then to see whether they can decrease the pulmonary vascular resistance. This is a key factor to determine whether the drug is effective or not. And you can see that this is the decrease change of the almost 240 dynes per second per centimeter. So basically, that's equal to about 3 Wood units. Wood units is, as you know, it's the measurement of the pulmonary vascular resistance. 3 Wood unit decrease is dramatic. Okay, so this result, this is with the 0.7 milligram per kilogram injection, and if you use lower dose, you have less effect. But this is a really positive effect, and this leads to the company to proceed to the next phase, which is phase 3, to see whether this drug can really help patients. This is just show that there's a pulmonary vascular resistance changes. And this is a Stellar trial, which is a phase 3 trial, and also published 2 years later. And the main finding is in this study is that the primary endpoint for this study is the 6-minute walking distance. Basically, test the patients how long, what's the distance they can walk after receiving the drug. And you can see this is the group patient received just a background therapy, vasodilator. They already improved their symptom. And this is the group patient on top of the background therapy, they receive additional dose of sotatercept. And you can see after 24 weeks, they can improve their walking distance for about 41 meters. This is dramatic in this field. You think about the patients that already receive a background therapy, and then they still can walk further. So that means really positive result. And when you talk about the time to the first occurrence of death or non-fatal clinical worsening event, which is basically called a clinical worsening time. And if the patient received the background therapy, this is the Kaplan-Meier survival plot. You can see the patient still died even they received treatment. But however, if you receive sotatercept, the patient survive longer, and the risk decreased about 84%. So this is dramatic. This is just the 2 main results, and also in addition to this primary endpoint, they test the 9 secondary endpoints, and 8 of them are positive. I don't have time to go into details, but the only one that didn't show much difference is the questionnaire to ask a patient whether they see any improvement in cognition or emotion impact, which is not necessarily directly related to the pulmonary hypertension. But that's the only one negative. The other 8 factors, including pro-BNP, all are positive. So and also the test from the study, we test the adverse event. The main adverse event is related to bleeding because the drug originally is used for anemia treatment, where I will come back to later. But generally saying, they are very safe. And therefore, the FDA approved this drug on March 26th. Okay, and then I talk because of after FDA approved this drug, the company is still testing this drug in different patient population, and then end up into another 2 New England Journal of Medicine publication in the past year. One is they try to see the patient in the high-risk death group. The other one is in the earlier diagnosed patient group. So those are the 2 tests. The first one is the Venice trial. And as I mentioned earlier, they choose the high-risk patient for death. Basically, the patient have been receiving standard treatment for many years, but still have very high risk for death. And then they, on top of this background therapy, they gave them sotatercept to see whether they can improve to see whether there are any beneficial effect. Indeed, the patients really improve their efficacy as a primary endpoint, and the clinical worsening risk decreased 76%. Okay, that's dramatic for survival. Okay. And then the second group they want to test to see, okay, what about the early newly diagnosed patient who was just diagnosed in the past year? Okay, basically it's a naive patient, didn't receive much treatment, and whether we use the sotatercept have any beneficial effect for this group. This is normally the young group, okay, patients. And this trial called the Hyperion trial. And the same thing, if you look at the survival rate and the first time of clinical worsening, and the risk decreased 76% with the sotatercept compared to the group with only the background therapy. So that means that, this is dramatic. So both the Zenith trial and this Hyperion trial have to end the trial earlier before they finish the trial, because the result is so overwhelming, and the DSMB have to stop the trial earlier to consider benefits for the patients. Okay, so just to summarize what I showed you earlier, there are 4 trials has been published in New England Journal of Medicine. This first one is Pulsar that showed the PVR changes, the resistance really decreased. The Stellar trial is a phase 3 trial, basically show that it really can help patients to increase their exercise capacity. Because by measuring their 6-minute walking distance, they can walk longer, they can move further. And then the Venice trial, they basically test for the high risk, almost near to death patients, whether they have a beneficial effect that really can lower their risk for death. And then the last one is the Hyperion trial, and it's new patients with a year, and they still have a beneficial effect. The trial ended earlier. And then there's actually another ongoing Sotera trial. It's an open label trial and test the long-term effect or safety. This is more like a phase 4 trial, a post-market trial. And this one also end up the midterm analysis published in the European Respiratory Journal, which is also a prestigious journal, and the study is still ongoing. All right, so this is I think the recent most significant advance in this field. However, I think the message is the importance of this drug is not only the result, which you can read in the New England Journal of Medicine. So I want to tell you something about the background of this drug, because I happen to get involved in some of the investigator with them. And I think some background information can be shared with the investigator and be useful. The drug is initially developed by a small company called Acceleron in Boston and Cambridge, but initially called Phoenix Pharma. It's a small company, but it's not funded by a pulmonary vascular researcher. It's funded by a group of cancer researcher and molecular biologists. The most famous one is Tom Maniatis. If you are learning, you are being a grad student in the past 30 years learning the molecular biology, he's the author for the Molecular Colonial Manual, and that's a standard textbook while I was in graduate school. And also the other main founder of this company is John Masigua. It's not John, it's John. It's Spanish, spelled as John, but it's a guy, it's a John. And he is the founder of the TGF-beta role in tissue. And then currently he is serving as the director for the Sloan Kettering Institute of Cancer Center in New York City, which is one of the famous cancer center in the United States. And the goal, and also as I mentioned, they formed this company with a group of cancer researchers because they want to use it to study, develop a drug that to help cancer patients who receive radiotherapy or chemotherapy. Okay, and the main target of the disease is like osteoporosis, muscle wasting, anemia, diabetes, obesity. That's the original goal. But this is the first drug they developed in the company is the sotatercept. At the time they called it ACE-011. And then since the company is in Cambridge, as you know, it's very close to Harvard Medical School. And the company want to explore more indication for this drug. So they collaborated with one of the investigators from Mass General Hospital, who was a PhD researcher and have a background knowing the BMPR2 pathway. So he wanted to test whether it has an effect in the pulmonary hypertension, which shows positive effect in the animal. And this is totally by serendipity. And then the company see the positive result, decided to, okay, we switch direction. We focus on the pulmonary hypertension research, and this led to the publication of the first trial, this phase 2 trial, PULSAR trial in New England Journal of Medicine. And then once this result come out, the big company Merck heard about this drug, and they have a very good sense about the future of the market. They immediately talked to purchase this company, the Acceleron, and within 6 months, they purchased a company with $11.5 billion investment. And then they support the next STELLAR trial, which is the phase 3 trial. And in 2 years, they published this in New England Journal of Medicine. The importance of this drug is that this is a disease-modifying drug. The other drugs is just vasodilator. They do not change the disease. This is a disease-modifying drug, okay? I know my time is up, so I want to be quick. So, and then the drug really changed a lot of things. This is something I don't have to go through. It's just a new model. So the take-home message for this is a new way to develop drugs. It's a biologic drug, and it's a fusion protein. And the main important part is completely different from the traditional switch class of drugs. And it can be a disease-modifying drug and a reverse remodeling, which is the new future for this disease area to develop new drug. And this is what considered as paradigm shift drug. And I'm pretty sure there will be new paper coming out for this drug in different indications. So that will be coming in the next few years. So there are some other things I want to mention, but I probably have no time. This is another session I chaired at the American Society meeting. I will just fly through. But I'm just telling you that the main advances in the field, we are focused on the early diagnosis and also focus on the disease. Like for example, for Fieldomics, we want to focus on the omics study. So that I will just go through this. So the last message I want to send you is just upcoming. I'm going to host the NHLBI workshops. That means we get all the experts online to discuss how we can diagnose the disease earlier, and also how can we accurately diagnose the disease. So this workshop is free to public, and free registration. It's online only. You don't need to fly over to the United States. And it will be on November 2nd and 3rd, which is Monday and Tuesday later this year. The registration website will be open probably next month. We are working on that. And everybody who are interested in this field are welcome to register. It's a free workshop for 2 days. So, and I think that's it. And thank you for everyone's attention. If you have a question, feel free to ask me. Thank you.
Thanks, Dr. Lei, for this wonderful summary of all the new treatment in pulmonary hypertension. Is there any question for Dr. Lei? We can take one question. If nobody has, maybe I can ask one. So, sure. Dr. Lei, compared to this is like a activin inhibitors, right? So compared to the endothelin receptor, antagonist, how this one is more, improved or better in terms of treatment?
So Sure, that's a good question. So as I mentioned earlier, all the other endothelium receptor antagonists or the natural oxide pathway, they only have one mechanism, is try to dilate the blood vessel. As I mentioned earlier, if the blood vessel is blocked by thrombosis or by because of the proliferation of the inside of endothelium cells, there's not much space for the blood to go through. Even you try to dilate it to a certain extent, and then after a couple of years of treatment, the patient are tolerated to the patient, not very sensitive to, not to the patient, to the drug. So the ERA drug will not be very effective in dilating the vessel. However, for this activin, this is basically inhibited the pathway that stimulated the proliferation of the endothelium cells, muscle cell. So theoretically, there's a way that the thickened blood vessel wall can be thinner. So that's making more blood can go through. That's what we call a disease modifying drug, because the other drug didn't modify the disease. This can really fundamentally change the problem, because the problem is because the thickening of the wall. Now we can thinning the wall. So we believe this is something that paradigm shift changes. So that's why I think this is a very exciting new drug, and it's the most exciting recent advances. So that's
affecting the vascular remodeling, basically, right?
Yes. That's the future direction for this field of research, drug development. So that's personally, I believe that's the direction. All right.
Okay. Thank you very much, Dr. Lei.
Thank you.
So I think we should move to the second talk of the session, and our next speaker is Dr. Jingwei Tiang, and he's going to talk about extended dual antiplatelet therapy in patients with coronary artery disease. So Dr. Jingwei.
Okay. Okay. Thank you for okay. Thank you for the invitation. Professor Jing Wei Tian has an emergency and cannot be here today. So I present for him, and I'm very happy to share our recent work. It was a large study called the DAPT-MVD. The full name is extended dual antiplatelet therapy in patients with motivation coronary artery disease. This study was funded by National Natural Science Foundation of China. Also, Dr. Peng has no conflict of interest to declare. In our study clinical work, we saw many patients with coronary artery disease. Among these patients, MAD is very common. In fact, if we look at all the patients who get a PCI procedure, about half of them have motivational disease. This is a very large number. Over the years, we have saw the result of many large clinical trials. There was a large study to teach us an important lesson. Even we do a perfect job during the surgery, and we open all the block vessel, the problem is not totally fixed. We also give us standard treatment, but still the risk of having another cardiovascular event is still very high. What does this mean for us as a doctor? It means that just open up the blood vessel is not enough to keep the patient safe. The danger doesn't just disappear. Even after a successful PCI, MVD patients still face a high residual risk. Because of this, we cannot just rely on the surgery alone. After PCI, we must rely heavily on long-term medical management. We need a good drug therapy to know this remaining risk. That is the only way we can truly improve the long-term outcome for our patients. Right now, DAPT is our standard treatment. We use it to prevent blood clot after PCI. If we look back the clinical guideline from 2007 until now, from both the ESC and the ACC or AHA, The main advice is very similar, and the evidence is getting stronger every year. For patients with SS who just has a PCI, the standard rule is to give them debt for 12 months. But we also know that some patients have a higher risk than others. For those high-risk patients who we cannot use a simple rule, we have to look at each patient and make an individual decision. Both Chinese and international guidelines agree on one point. They say that if a patient has a high risk of ischemia, but a very low risk of bleeding, some patients think about extended DAPT. That means giving the two antiplatelet drugs for longer than 12 months. However, making that choice is very hard. Large meta-analysis show us that extending depth gives us a high rewards, but also high risk. On the good side, it clearly stop more chemical events, but on the bad side, it causes a lot of more bleeding. That is a very heavy price to pay to solve the problem. We must understand how the patient's risk changes over year or over the time. The risk of bleeding stays pretty much the same. It doesn't change much from month to month, but the risk of ischemia is very different. It goes down significantly over time. In the early days right after the surgery, ischemia risk is very high, so we must use the strong drug. But when we reach the 12 mark, some changed. The blood vessel had healed inside, some of healing. Most MVD patients enter a safety and stable phase. The risk of ischemia dropped down a lot. So, bring us the bigger question. For those MVD past 12 months, what should we do next? How can we give them safe and effective therapy? We need to find the balance. We want to prevent ischemia, but we also want to avoid bleeding. Find this perfect balance is the key to improving this prognosis in the long run. To answer this question, we started the DAPT MVD study. Our main goal was to test the efficacy and safety of non-treatment. We focused on the MVD patients who had no clinical events for 12 months after DES implantation. For these stable patients, we compared giving one an additional 12 months of depth, clopidogrel plus aspirin, against giving aspirin alone. We designed the study this way for a clear reason. 12 months after PCI, MPD patients reach a stable phase, but their long-term ischemia risk is still high. Also, compared to non-drugs, clopidogrel is much safer and causes less bleeding. The WMVD study is a randomized multi-center trial. It was an open-label study, but the people tracking the endpoint are well blended. We worked with many hospitals across China and successfully enrolled 8,250 MVD patients. All these patients had received the DES 12 months ago. More important, they had no events during the first year. We randomly divided these patients into two groups. The first group got extended depth, meaning they took aspirin plus clopidogrel. The second group got aspirin monotherapy, means that they took aspirin alone. They set up several follow-up time points that help us carefully record all endpoints events. But that study, our primary endpoint was missed. They include cardiovascular death and no fatal myocardial infarction and no fatal stroke. When screen patients, we focused on specific group. They had be MVD patients because 18 and 50 and 35 years old. They also need to be stable 12 months after DAS initiation, and they must be stable uh, uh, be able to take to keep the student take a anti-platelet study and open 123 clinical centers across China, and 97 of them successfully enrolled patients. We carefully screened 9,100 to 27 potential candidates, and we include patients who didn't meet our rules. In the end, we successfully randomized 8,250 patients. You can see the detailed study flow chart in the slide. Now, let's see the baseline data. The clinical and the procedure baseline was balanced between the two groups. The average age of all patients was 31 years old. About 30% of them were female, and 28% had diabetes. One important point to note is that almost all patients has ACS during their index PCI. Also, 21% of them have international intervention on multiple vessels. First, let's look at the IgG population. We observed that the rate of mass was 5.8% in the extended adapter group, and the rate was 6.8% in the aspirin alone group. Furthermore, the benefit of primary endpoint was highly consistent. There was we saw this benefit in both ITT and PP population. Also, this trend studied the same both before and after multivariable adjustment. And at the same time, we also look at the win ratio analysis. The result was very clear. The extended depth group and had a more high winning rate for mass. It clearly beats the aspirin group. The final win ratio was 1.22. Next, we did the subgroup analysis for the primary endpoint. We can see the benefit of extended depth was very constant. It worked well across almost all groups. We only saw the one possible difference. That was in patients with different BMI. Then we found major past study very well. Already know the high BMI often cause a poor response to therapy. Now, let's look at the second endpoint of analysis. We look at that dropped in mass event was mainly driven by one thing. There was a minor reduction in the risk of myocardial infarction. In fact, the relative risk dropped by 32%. More important, That was a big job in ischemia event that didn't cause more bleeding. We saw no significant difference between the two groups for back type 2 to 5 bleeding, and the same was true for back type 3 to 5 bleeding. Moreover, we did several sensitivity analysis. In all of them, this rule remains very strong. Of course, our study does have a few limitations. First, the study was an open-label study to prevent any bias, or even all endpoints was judged by blinded committees. Second, our results only apply to clopidogrel. We cannot the same for stronger drug. Also, we didn't compare the extent depth with taking clopidogrel alone. Finally, all of our patients from China. We also careful when applying this result to our other population. In conclusion, our study give a clear answer to stable MVD and SS patients. 12 months after DS implantation gives them an additional 12 months of depth is highly effective compared to aspirin alone. Clopidogrel plus aspirin significantly lower the risk of MAS. And most important is this without increasing the risk of bleeding. This is the end of our presentation of depth DAPD MAD study. Thank you very much.
Yeah, thank you very much for this great talk. I would like to invite anybody if there's a question. I think if there are no questions, then maybe we can move to the next talk. Thank you.
Okay.
Okay. Okay, can you see my slides?
Yes, we can see you.
Professor
Yes,
Zhang, we can see your slides.
Okay. Okay, one second. Okay. Okay, thanks a lot for the invitation. And I'm very, very happy to be here and talk about some of the work we are doing at Duke University Medical School in Singapore. And for today's talk, I'll be talking about a role of hypersignaling mediators, YAP and TAZ, in inflammation and fibrosis. So as you all are familiar that cardiovascular diseases are the leading cause of mortality worldwide. Around 30% of all the deaths are due to cardiovascular diseases. And among all the cardiovascular diseases, ischemic heart disease is the most common one, followed by dilated and hypertrophic cardiomyopathy. And these numbers are going to go significantly increase as we know that cardiovascular risks are associated with aging and populations are getting older in Asia as well. So definitely we need to prepare better to tackle the cardiovascular disease-related mortality. So my lab has been working on an epicardium. So epicardium is a structure which is present at the base of the heart. It is derived from a transient structure known as proepicardial organ present at the base of the heart. So prior to heart looping, the heart tube has two layers, endocardium and myocardium. And proepicardial cells, they proliferate, migrate onto the surface of the heart and form the third layer or the outermost layer that is known as epicardium. So soon after the epicardium is formed, a subset of these cells undergo epithelial to mesenchymal transition. They invade the underlying myocardium and differentiate into multiple cardiac cell types. So these cells can differentiate into fibroblasts, smooth muscle cells, and we have previously shown that they also have a potential to differentiate into cardiac or coronary endothelial cells. In addition to working as a cell source, epicardium also acts as a signaling center. Epicardial signals regulate myocardial growth, as you can see in this image, that in absence of epicardium formation, myocardial compaction is significantly compromised. Epicardium is not only necessary during embryonic development, but also plays an important role in adult heart, especially during myocardial infarction. So in adult heart, most of the time the epicardial cells are quiescent, means they do not proliferate. But after myocardial injury or ischemic injury, a fetal gene program is activated in the epicardium, leading to proliferation of the epicardial cells and their subsequent differentiation into cardiac fibroblast and smooth muscle cells. In addition to that, activated epicardium also secretes paracrine factors to modulate the repair response after myocardial injury. So if we know all the factors that play critical role in the epicardium during this process, we might be able to modulate the overall regenerative response in a positive way after myocardial injury to improve cardiac functions. So we have been working on this one pathway, Hippo pathway, from almost last 10 years. So let me briefly introduce this signaling pathway. The Hippo signaling pathway is a kinase cascade leading from an upstream kinases, MST1 and 2, to downstream effector proteins like YAP and TAZ. So upon activation, upstream kinases MST1 and 2, together with a regulatory protein known as Salvador, phosphorylate LATS1 and 2 kinases, which subsequently phosphorylate the transcriptional coactivator YAP and TAZ. So once YAP and TAZ are phosphorylated, they can stay in the cytoplasm. Or when they are not phosphorylated, they can translocate to the nucleus and interact with a number of transcription factors, including TEAD factors, TEAD1 to 4, and regulate target gene expression. So when we started working on Hippo signaling and trying to establish its role in the epicardium, there was nothing known about its role. There was already established function of Hippo signaling in the cardiomyocytes, but not in the epicardium. So we decided to look whether, first thing was to look whether YAP and TAZ are expressed in the epicardium, and we found that yes, both YAP and TAZ as well as other component of the Hippo signalings, they are expressed in the epicardium. And to understand their function, we decided to delete YAP and TAZ in the epicardium and to see what kind of coronary vasculature defects that can cause. So we decided to use two different Cre lines. One is SEMA3D Cre, which is epicardium specific Cre. And the problem with the SEMA3D Cre was that when we deleted YAP and TAZ with SEMA3D Cre, majority of the animals died as early as embryonic E11.5 day. And at this stage, the heart doesn't have a coronary vasculature, so we could not determine the effect of YAP-TAZ deletion on the coronary vasculature. So to avoid early lethality, we deleted YAP-TAZ with the tamoxifen-inducible WT1 Cre and analyzed the coronary vasculature. What we observed that there were a significant reduction in the coronary vasculature. Most of the microvasculatures were affected. We also observed that there are vessels which are not positive for PCAM1, which is a marker for the coronary endothelium, suggesting that the impaired coronary vasculature remodeling. So to determine the cause of this coronary vasculature defects, we perform a number of experiments to assess epicardial cell proliferation, epithelial to mesenchymal transition, as well as we did linear stress analysis to determine epicardial cell fate changes in control and YAP-TAZ double knockout hearts. So to cut the story short, we perform a number of in vivo and in vitro experiments to show that epicardial YAP and TAZ regulate epicardial cell proliferation, EMT, as well as epicardial cell fate, in part by directly binding to two transcription factors, TBX18 and WT1, and thereby regulating their expression and function. So we thought this is a very interesting function of YAP-TAZ in the epicardium. So because if we delete YAP and TAZ in the epicardium, epicardial contribution to fibroblast is compromised. So if the this function is conserved in adult epicardium, what we can do is we might be able to inhibit their expression and to control excessive fibrosis and adverse remodeling what we observed after myocardial injury. So if you look at the repair process after myocardial injury, we can divide that into 3 phases. The first one is inflammatory, where the immune cells invade and the ischemic tissue and the secrete cytokines, and that helps to remove the dead cells. The second phase is proliferative phase, where the fibroblasts proliferate and differentiate into myofibroblasts and secrete a lot of extracellular matrix, and endothelial cells help to revascularize the ischemic tissue. And in the final phase, the vascular tissue remodeling occurs, leading to the formation and maturation of scars, causing functional defects like arrhythmia in the heart. So our first goal was to see whether YAP has activated. So we do see activation of YAP and TAZ, but when we decided to use the same mice which we use for the embryonic study to establish YAP-TAZ function in the adult epicardium after ischemic injury. And what we found that loss of epicardium YAP-TAZ results in cardiomyopathy and increased mortality after myocardial injury. But what about fibrosis? So when we look at the heart fibrosis, we observed that there was a significant increase in fibrosis in the YAP-TAZ knockout hearts. And this was not what we were expecting based on our observation during embryonic development. We were expecting that the loss of YAP-TAZ will reduce epicardial-derived fibrosis, but in contrast, we see massive excessive fibrosis in these animals. So how to explain this excessive fibrosis phenotype? One thing what we noticed while harvesting the heart was that the hardware, the chest cavity was severely inflamed in YAP and TAZ knockouts compared to the control. So we performed an immune array on the ventricle wall and found in this screen that many of the inflammatory genes were significantly affected, including IFN gamma, whose expression was significantly downregulated. So at this stage, we didn't know even if IFN gamma is expressed in the epicardial cells. So we performed a RNA scope in situ hybridization, and we established that we found that IFN gamma is expressed in the epicardial cells post myocardial injury. We did further experiments to demonstrate that epicardial YAP-TAZ can directly bind to IFN gamma promoter and regulate expression in the acute recovery phase after myocardial injury. One of the established functions of IFN gamma is to regulate homing of regulatory T cells. So we analyzed FOXP3 positive Treg cells and found that YAP-TAZ deletion results in impaired homing of regulatory T cells to the injured heart. And one of the most established function of regulatory T cells are that they are anti-fibrotic in nature. So in YAP-TAZ knockouts, when we delete, we see less IFN gamma, leading to a reduction in the number of Treg cells, means there is a reduction of anti-fibrotic function, leading to more fibrosis. We also try to rescue the phenotype by supplementing the heart with the IFN gamma supplemented hydrogel. And what we found that we observed significant improvement in the number of FOXP cells, leading to improved fibrotic response. And not only us, but others have also shown in other independent labs that selective depletion of regulatory T cells using diphtheria toxin model can negatively affect ischemic injury response. So that makes sense with what we have observed. In the YAP-TAZ knockout, not only we observed reduction in the number of Treg cells, but we also found that there is an increased infiltration of macrophages, and macrophage populations are known to promote regenerative response in younger mice after ischemic injury, or they mediate fibrotic response in adult heart after myocardial injury. So I will come back to that in a minute. But before that, just to summarize what we observed with this epicardial YAP-TAZ mutant, that what we think is happening is the unexpected increase in fibrosis suggests that the paracrine effect of the epicardium on immune cells is overriding the intrinsic antifibrotic effect of YAP-TAZ loss in the epicardium-derived fibroblasts. So although YAP-TAZ deletion in the fibroblast would be expected to reduce fibrosis. The excessive immune response, particularly driven by macrophages and T cells, they predominate and result in excessive fibrosis. So how to prove this? We decided to directly assess the cell autonomous role of YAP and TAZ in fibroblast by generating a fibroblast-specific YAP and TAZ knockouts. And in contrast to what we observed in the epicardial YAP-TAZ knockout model, fibroblast-specific deletion led to reduced fibrosis, supporting an anti-fibrotic role of YAP-TAZ in fibroblast. Coming back to the macrophage, as we know that following ischemic injury, macrophage polarization determine the fate of fibroblast and the fibroblast-mediated excessive fibrosis or extracellular matrix accumulation. So given the central role of macrophages in coordinating post-MI healing, we decided to ask whether YAP-TAZ also regulate macrophage polarization and function during cardiac repair. So we found that YAP-TAZ expression was upregulated in mouse macrophages, BMDM-derived macrophages, in response to M1 stimuli, which is LPS and IFN gamma. And if we do siRNA-mediated knockdown of YAP-TAZ, it significantly reduced the expression of pro-inflammatory genes. After seeing the convincing in vitro results, we decided to generate a macrophage-specific YAP and TAZ knockouts models and examine the inflammatory response following M1 polarization. So consistent with our in vitro findings, we found the deletion of YAP-TAZ resulted in a marked down regulation of the majority of the pro-inflammatory genes, demonstrating that YAP-TAZ is required for the establishment of a pro-inflammatory macrophage program. We also demonstrated by a number of in vitro experiments that YAP-TAZ can directly bind to a pro-inflammatory genes known as interleukin-6 directly on their promoter and regulates its expression. So this altogether data suggests that YAP-TAZ acts as an activator on IL-6 promoter and regulates its expression. In contrast, when we look into YAP-TAZ role in M2 polarization, we found that YAP-TAZ suppresses the expression of M2 associated pro-fibrotic or anti-inflammatory genes, including arginase 1. So this indicates that YAP-TAZ exert distinct polarization-dependent effect on macrophage phenotype. So in contrast to M1, M2, YAP-TAZ are also activated, but they act as a repressor on the M2 polarization genes like arginase 1 shown here. So what determines the difference in YAP-TAZ behavior in M1 versus M2? So we decided to look further into M2 macrophage polarization, that what is the molecular mechanism by that YAP-TAZ are repressing arginase 1 function. And what we found that YAP-TAZ can directly interact with HDAC3 ENCO repressor complex in macrophages and inhibit the arginase 1 promoter activity shown here. So next, we try to determine, because HDAC has the two functions. One is the enzymatic function of histone deacetylase 3, and the second one is the structural function of HDAC3. So we decided to do a bunch of experiment, luciferase assay experiment, exposed to pan-HDAC inhibitor, HDAC3 specific inhibitor, and we also used a mutant form of HDAC3 that has no enzymatic activity. And using all these assays, we demonstrated that deacetylase activity of HDAC3 is not required for arginase 1 repression. So what is the effect of these changes in macrophage polarization on cardiac function? We performed echocardiography and observed that macrophage-specific YAP-TAZ knockouts are protected from injury and show better ejection fraction and fractional shortening shown here. We also observed there is the improved ventricular remodeling in YAP-TAZ knockout heart, shown here by reduced fibrosis and collagen deposition. Many of the genes that are known to regulate myofibroblast formation and collagen biosynthesis and remodeling, they were significantly downregulated in these double knockout hearts. In addition to reduced fibrosis, we also observed improved angiogenesis in double knockout hearts, contributing towards a better repair response post-MI. So just in summary, our results demonstrate that YAP-TAZ modulate macrophage polarization in post-MI heart and associated immune response, thereby affecting cardiac repair response following myocardial infarction. So just in summary, our findings demonstrate that in contrast to their beneficial role in cardiomyocytes, YAP and TAZ activation in fibroblast or in macrophages promote pro-fibrotic and pro-inflammatory program, leading to increased or excessive fibrosis and impaired cardiac function following ischemic injury. So now what we are trying to do is we are trying to use chemical inhibitor to inhibit YAP-TAZ activity in different fibrotic conditions to see whether using a chemical inhibitor that targets this pathway can be used to improve cardiac function after ischemic injury. Another question we asked was that whether this molecular mechanism of pro-fibrotic and pro-inflammatory response we see driven by YAP and TAZ, whether this is also conserved in other organs or other tissues after injury. So to determine that whether the role of YAP and TAZ in macrophage-mediated immune response is conserved across tissue, we extended our analysis to a mouse model of pulmonary fibrosis. So although I will not go in detail, this paper has been last year published, so you can take in more details. But just to summarize that also the underlying molecular mechanism is different than what we observed in the cardiac fibrosis. YAP has similarly regulated macrophage-driven inflammatory and fibrotic response in the lung also, indicating that YAP has a conserved function across different organ systems in regulating fibrosis and inflammation. So with that, I would just like to stop here and acknowledge my lab members for their contribution to this work, as well as the funding agencies for supporting our work. I'm also grateful to your attention and would be happy to take any questions that you may have. Thanks.
Thanks for the great presentation, Dr. Kumar. I have a question.
Yes.
You can hear me? Yeah. Okay, good. So,
yes,
the YAP pathway is also indicated in pulmonary hypertension. So, I just wanted you to know that in your case, in the ischemic heart, do you think the overall activation of this pathway is beneficial or is it detrimental to the heart regeneration? Because currently you are talking about it helps to repair the heart, the different cell types, and also your research presented that it can be pro-fibrotic and pro-inflammatory effect. So what do you see overall of this pathway to see the net effect, whether it's beneficial or it's detrimental? So that's the question I'm trying to figure out.
Yeah, very, very interesting question. So the issue has been, at least let's talk about the cardiac repair. So in cardiomyocytes, people have shown that if you inhibit YAP and TAZ, if you activate YAP and TAZ, that can helps to make cardiomyocytes to proliferate more. So that's a good thing. But in our experience, the effect is very, very limited. Compared to after ischemic injury, YAP is activated in macrophages and fibroblasts, driving the negative effect on the repair process. So my guess is that if you inhibit the whole pathway in terms of either lung fibrosis or cardiac fibrosis, you will see a beneficial effect. Not the hippo pathway, but the YAP-TAZ mediated.
All right. Okay. Thank you so much.
And just to add, we already have done that experiments using two different inhibitor. One is a YAP-TEAD inhibitor, and the second one is TEAD inhibitor, which has been going on a clinical trial by Vivace Therapeutics in US. And we see there is a net positive effect after lung fibrosis. So definitely targeting this pathway could be helpful. And as you may know, this pathway is more studied in a cancer field than in a cardiac or lung. And there's a lot of effort people are trying to affect this pathway or inhibit this pathway to control tumor growth.
All right, great. Thank you so much. Appreciate it.
Any other question? If not, then maybe we can move to the next talk in this session. Any other moderator wants to introduce the last speaker?
Okay. I will do this job.
Okay.
Okay.
Thank you.
The next speaker is Professor Chen from the Wuhan Tongji Hospital, and the topic is non-coding RNAs in heart failure. Welcome.
So good morning, everyone. Professor Liu, is the slide okay?
Yes.
Okay. Yeah, good morning. It is my great honor to be here to have the chance to present our recent work about the non-coding RNAs in heart failure. I'm Chen Chen from the Department of Cardiology, Tongji Hospital, that's in Wuhan. And so let's start now. Heart failure is a complex set of clinical syndrome. It is caused by abnormal change in the structure or function of the heart caused by various etiologies, including we know that CHD, cardiomyopathy, and hypertension. And also multiple cell types such as the cardiomyocytes, fibroblasts, endothelial cells, and inflammatory cells participates in it. Now we know that the classical mechanism of therapy are mainly protein-based, but according to the central dogma, only about 1% of our human will finally encode protein. Most of them, yeah, we know that is called a non-coding RNAs. So our team focused on the RNA world, especially the non-coding RNAs. Now we know non-coding RNAs can be classified as length in a short one as siRNA, microRNA, and the long one as long non-coding RNA. And if it is can form a circle, it's called the circle RNAs. Among them, the most famous one we know is the microRNA. It is first microRNA was discovered in 1903 by Victor Ambro. Its distinguished work. They found the first microRNA in C. elegans that called the LIM4. And then Victor Ambro, Professor Victor Ambro and Professor Guy Rufkin, they together discovered the distinguished regulation form of microRNA and its role in post-transcriptional gene regulation. The well-known classical mechanism of the microRNA is in the cytoplasm. MicroRNA bind to the 3' UTR of the target genes and inhibit their expression. So our group mainly focused on the function of differentially expressed non-coding RNAs in various cardiovascular diseases, especially in heart failure. So we collected the hearts of normal controls and patients with heart failure for their transplantation. We take their samples and detected the microRNA expression profile and long non-coding RNA and the other non-coding RNA expression profile, screening the differentially expressed non-coding RNAs and further investigate their functions in different cell types that we have named them previously. And we found a series of non-coding RNAs that can be used as biomarkers of our cardiovascular diseases. Meanwhile, we discovered the underlying normal molecular mechanism of non-coding RNAs in heart failure. So first, we try to identify the microRNA expression profile and the change in patients with heart failure. Then we detected the expression pattern. Especially interestingly, we found that microRNA such as miR-21 was increased in the mitochondria during heart failure. To determine the potential effects of miR-21, we transfected the miR-21 mimic and found that the mitochondria genome encoded gene expression, we know that is mitochondria ND1, mitochondria cytochrome B, especially, it was increased, it was enhanced. So since the well-known mitochondria classical mechanism of microRNA is not in mitochondria. So we wonder how to distinguish the classical cytoplasm effects. So to rule out the indirect effection of the microRNA via cytoplasm target, we perform the diagnostic analysis on the differential requirement of the AGO2 cofactor, that is GW182, which is required for the microRNA effects in the cytoplasm, but not in the mitochondria, since it was not found in mitochondria. As expected, we know that GW182 knockout and knockdown prevented the miR-21-mediated translational repression of its cytoplasm target PTM. But also under these conditions, the GW182 RNAi treated cells continued to show enhanced cyclin B translation by the miR-21 mimic. So to determine how miR-21 might enhance the expression of cyclin B at the protein level, we perform the polysome analysis. That is a gold standard for starting the translation regulation. So significantly, by the real-time quantitative PCR, we detected an increased cytochrome B mRNA in polysome fraction, that is fraction 12 and 13, in response to transfected microRNA miR-21. So this data suggested that miR-21 directly enhanced the cytochrome mRNA translation in the mitochondria. So in heart failure, the translational activation ability of microRNA AGO2 in cardiomyocyte mitochondria decreases, and the antioxidant proteins are reduced. So the mitochondrial energy metabolism is impaired and the cardiac function is dismissed. Our work was identified as one of the unconventional microRNA functions by cell. Further, we wondered that why, also as the protein, GW182 is not in the mitochondria, but AGO2 can enter into the mitochondria. We use the mass and the proteomics analysis, and results show that due to the reductions in the cytoplasm short form of SIR3, we know that SIR3 is also 28 kilodalton, and it is in mitochondria. But we found a short isoform that is 25 kD, and in the cytoplasm to perform in myelination modification. So the AGO2 modification increase and leading to the decrease in the binding of AGO2 to the mitochondrial transport, that is TIM 17B, and the block its transport into the mitochondria. So consequently, the level of mitochondria AGO2 decreased significantly, and the translational activation mediated by the mitochondrial AGO2 in mitochondria is inhibited, leading to the mitochondrial energy metabolism disorder and the heart failure. So our previous work will mainly focus on the role of microRNA in different organelles. We not only review the conventional roles in mitochondria, but we also found the conventional roles in the nucleus, that is target gene transcriptions. We found that as one of the mainly important regulation in the cells, maybe microRNA can be the targets. So we searched for the therapeutic discovery for microRNA delivery. But we know that for the therapy, it is hard to deliver microRNAs to different organelles. Even though we have the target organ delivery system, but we did not have advance in the organelle delivery system. So we found that one of the important components, that is AGO2 protein. As a protein, it is also involved. So we want to explore whether as a protein, AGO could be a potential target. We know that we can to deliver a protein to the organelles more easily compared to the microRNA. So using the how about the AGO2 system? So using the heart samples from the patients with heart failure, we found that AGO is significantly increasing the heart of heart failure patients with hyperlipidemia. So that is the results from our human samples. And to test whether AGO2, the core components of the microRNA risk machinery, is functionally involved in the heart failure that is associated with the HFA diet. So we used the HFA diet to induce the heart failure mice model. So we found that HFA diet treated mice were in their heart, the AGO2 expression were significantly upregulated as compared to the other AGO family protein. So we know that maybe one protein increase maybe benefits or maybe damage to the heart. So consider it that the AGO2 was predominantly expressed in cardiomyocytes in the heart. We knocked down the AGO in the cardiomyocytes using shRNA delivered by the AAV9 system under a cardiomyocyte specific, that is the troponin T promoter. So notably, we found that cardiomyocyte-specific knockout of AGO2 improves cardiac function, cardiac hypertrophy, and importantly, it reduced the lipid deposition. So we know that AGO2 has been reported to regulate gene expression in transcriptional and post-transcriptional manners. We in both ways. So we use the LC mass analysis, and we found that two important enzymes, that is HMG-CSH2 and BDH1 in ketone metabolism, were identified as the potential targets of AGO2. So next, we test whether AGO2 directly or indirectly regulated this gene expression. So we used AGO2 chip PCR, and we found that AGO2 showed directly binding events on the HMG-CSH2 promoter DNA, but not the BDH1 promoter DNA. In parallel, we found that AGO2 PCR revealed that AGO2 was neither associated with the HMG-CSH2 mRNA nor BDH1 mRNA. Moreover, we used the loss of function AGO2 mutant plasmid lacking the enzyme activity, and we found AGO2 enzyme activity is required for the transcriptional activation of HMG-CSH2. So we know that HMG-CSH2 is the rate-limiting enzyme in ketogenesis, so which can produce the ketone bodies. That is about 70% is beta-OHB. It is used as the energy substance for extrahepatic tissues when glucose is lacking. It was mainly oxidated in the mitochondria and also in the plasma. It can induce the lipid synthesis. So interestingly, we detected the ketone bodies in our system, and we found that an upregulation of beta-OHB level in the heart of the HFA diet treated mice, and if we knock out the AGO2 in the cardiomyocytes, we can see that the ketone production in the heart is significantly reduced. And the AGO2 HMG-CSH2 ketone body signal pathway is mediated by the ketone production, and also HMG-CSH2 can reduce the protein level of BDH1. We know that on one hand, the production of ketone is induced by the overexpression of HMG-CSH2, and on the other side, as the BDH1, which can lysis the ketone, is decreased, so they together produce the more ketone bodies in the heart, which is significantly over the threshold. So the ketone body, we know that it may have benefits, but overexpression over the threshold, it may have damage in the heart. So we want to know what is the potential targets of the ketone body. Then we still perform the LC-MS, and we use the signal pathway analysis and the species homolyze, and also we double check in our second cohort, and we found the important targets of ATP and UQCR, especially as they were also both involved in the electron transport chain that is very important in the mitochondria. So we detected the seahorse axis in our system, and we found if we overexpress the HMG-CSF2, and we found that the ATP production and OCR is decreased, and on the other side, the lipid deposition is increased. So HMG-CSF2 mediated the half-adult-induced AGO2 to promote the metabolism disorder in the heart, especially the ketone body toxicity and the lipotoxicity. As we know that our model is half-adult-induced heart failure. And then in the cardiomyocytes, the ketone body was increased. And the ketone body increase in turn induced the lipid deposition. So they mutantly promoted each other and formed the circle and to promote energy metabolism disorder. Yeah. So if we want to stop the circle, we have to stop the expression of AGO2. AGO2 protein level is increased. We want to know whether it's a transcriptional or translational manner. So we detected the mRNA level of AGO2, and we found that the mRNA was increased since 8 weeks after our treat. So we know it's a transcriptional level managed regulation. So we use the bioinformatic and the biological validation, and we found that the classical pathway that is under the lipid disorder, that is PKC alpha, ERK EGR1 pathway, it mediated the AGO2 induced transcriptional activation by half-adult, and as the mRNA is increased, the protein level is also increased. So half-adult induced both the cytoplasmic and the nuclear AGO2 levels. So how the AGO2 can transport it from the cytoplasm to the nuclear, and we found that APO8 mediates the nuclear entrance of AGO2. So the half-adult promotes the nuclear entrance of AGO2 via the APO8. So since we have both increased in the cytoplasm and also in the nuclear, so which one may contribute to the damaged heart failure? So we use this strategy. We use the NES or NLS peptide to overexpress the AGO2, especially in the cytoplasm or in the nuclear. So we found that only the nuclear AGO2 expression exacerbates the half-adult-induced heart failure, not the cytoplasm. If the AGO2 was increased in the cytoplasm, it did not affect the heart cardiac function. So when we increase the nuclear AGO2, the heart failure were damaged, and also the HMG-CSF2 expression and energy metabolism disorder were enhanced. So increased nuclear AGO2 damaged the heart cardiac dysfunction through the lipotoxicity and the ketone toxicity system. So here we found the ketone body toxicity and the lipotoxicity in the heart failure, which was mediated by the PKC alpha, ERK EGR1 pathway, and especially through the AGO2 induced transcriptional activation by half-adult. And the increased nuclear entrance of AGO2 damaged the cardiac dysfunction by the lipotoxicity and the ketone toxicity system together and form the circle. So here we the European Heart Journal give us editorial called "ARGO is the nuclear power." We like the nuclear power the words because not only it was located in the nuclear, but also we think it is the core of power, core of the metabolism power in the heart. So finally, I would like to thank Professor Dawen Wang, especially I wrote the Chinese characters for their names. Yeah, I like to thank the Professor Dawen Wang for his support and also our colleagues and our friends. Thank you.
Okay. Okay, very good work. And is anybody have questions?
Yeah, can I ask a question? Can you hear me?
Yeah.
Thank you, Professor Xiao.
Yeah, sure. First of all, say hi to Dr. Wang Dawen. He's he's my friend. So, very great presentation and the good work. So, my question is, when you see the ARGO increase in the heart failure patient, is that in the left heart failure patient or in the right heart failure? What kind of patient the population you are tested in your study? Because the reason why I'm asking, I assume that probably you are mainly focused on the right heart failure patients samples. But recently there's an investigator also showed that for the pulmonary hypertension, that which is at the end stage of pulmonary hypertension, is the right heart failure, and they can see the lipid deposition in the right heart side. So I'm wondering, I'm not sure whether this is you have studied it, but I was wondering whether whether you will see the same thing for the ARGO increase in the right heart failure patients.
Thank you, Professor Xiao. I know your issue is very important. And as for the sample we collected here, we have both left heart failure and also the both left and right heart failure. We do not have the patients with only right heart failure. And the second point is we have detected the right and the left ventricular, especially using the single cell technique. And we did not find any difference in the expression of mRNA level, but we think its protein level may be different. So we still detect we use the proteomics assays, but ARGO2 is hard to find in using this way. And we use the Western blot. We found that they have a slight difference. And we know another issue is maybe the modification PTM is important in the ARGO function. So we're still producing the ARGO2 PTM detection in the right and the left heart failure patient sample. And it's very important that we know that in not only in the final stage patients, we know as you said, the etiology may be different for the heart failure patients. We have made many I think it's mice model to detect the right and left heart failure, the difference and the role of ARGO in the models. And I hope we have the data to answer you, and you can teach us more. Thank you.
Yeah, that's a very helpful information, because and also I suggest that if you have time or you have the resource, you can try to separate the pure right heart failure patient with the left heart patient, because some of the patients, they have the first have left heart left heart failure and then lead to the right heart failure too. So basically there's combination. So but if you can have separate the sample with pure right heart failure and with the pure left heart failure, and to see whether the ARGO expression level is whether there's a difference, and also whether the mRNA microRNA level is different. That will tell you something interesting to see, because there's always argument whether right heart and left heart have the same failure mechanism. Because for the right heart failure, if you do the lung transplantation for the pulmonary hypertension patient, the right heart can transform totally from a failure state to a normal stage. And we are not sure whether we can see that in the left heart. So there's always a question whether this is the same in the left heart and right heart. So if you have the samples, if you do a simple test to see whether there's any difference, that will probably have a very interesting research topics will present to you. For the future research, that will be a really interesting topic. Yeah, thank you.
Yeah,
but
thank you.
Very good. Yeah, thank you. That's it.
Thank you.
Maybe I can ask one question, Dr. Chen.
Thank you.
Yes. So I wanted to ask you about like a microRNA 21. So I remember like a long time ago, I think there was an initial Nature paper from Thomas Thom showing MIR21 function. And then Eric Olson's group showed that if you delete MIR21, there's like literally no cardiac function. So they said it's not required for any cardiac function. But I think you demonstrated that at least in diabetic cardiomyopathy, overexpression of MIR21 could be beneficial, right?
Yeah.
Yeah. So do you think the role of these microRNA is more like when you overexpress, you may see something, but if you lose it, there is no real, no important function, at least in case of MIR21.
Yeah, thank you for this issue. I know you. I know. We are good friends. We asked Thomas Toom. Yeah, we know that. Yeah, we also know that his great work about MIR21. He delivered the MIR21 in fibroblasts. Yeah, we think it's maybe the difference in the cell type, and maybe it's difference in the expression level threshold. We think it is balanced as the micron expression or any protein production. Too much or too less is or both will be damage to the heart for the whole systemic. So maybe it is important to know the threshold of its expression, not only in the cytoplasm or not only in the nuclear or not only in one cell type, but it is in the whole systemic. So we think it is we have to do more to collect our work with Thomas Thom. Yeah.
Okay. Just follow-up question, because you know Thomas, right? What is your opinion about, because I think they did the recent last clinical trial and there was no positive impact. So just your opinion.
I think it's a great job because it is the first one clinical trial in the heart failure field for
With
microRNA delivery. Yeah, it is and we know that it is 132. Yeah, we all both know that. It's very it's very exciting that we have a microRNA drug, and it is for the first one in our heart failure field. So even if we have maybe I think maybe due to the limited sample size, or maybe limited to we know that the delivery system is up to now, it is very hard for our cardiac dysfunction. We know that we have GalNAc for the liver, but maybe to our heart, we have endothelial cells to target, and we have our cardiomyocytes to target. So we maybe have to do some AOC or ADC. Yeah.
Yeah. Thank you.
Okay. I have a simple question. So is there any microRNA is transplanted by the mitochondrial DNA?
Yeah, thank you for your issue, Professor Liu. As we know up to now, because the microRNA processing have to some protein involved, that is dicer or dosha, but these proteins were not in the mitochondria. So up to now, we think maybe the microRNAs cannot be processed in the mitochondria. It has to be produced in the nuclear and to the cytoplasm, and then transport into the mitochondria.
Okay, thank you.
Thank you.
So the Professor Chen is the last speaker. So is there another speaker?
No, I think that was the last talk of this session, so we can wind up the session. So if is there any other moderator who wants to give the closing ceremony, I'm happy to wait for them. Is there any other moderator? Nobody wants to take this. Okay, then maybe I can just wind up. Okay. So on behalf of the moderator panel, okay, I would like to thanks all the speakers, no, Dr. Lei Ziao, Dr. Zheng Wei Tian, and Dr. Chen Chen, as well as all the fellow moderators for their wonderful job. And I hope at least we learned something. And I think one suggestion I have is that maybe we can share our email IDs through emails and try to see whether we can follow up later on and in case if we think of any kind of a potential collaboration and work together. So that's what we can do. With that, I think we can close the session. And I would like to thanks to all of you for a wonderful job. Thank you.
Thank you.
Thank you, everyone. Goodbye.
Yeah. Bye-bye. Bye-bye.
Dear colleague, dear friends,